welcome everybody to this breakout session using processes and tools to simplify MBQIP. All sessions are being recorded, including this one. Just a few things to throw out there, some housekeeping stuff. I'll reiterate the learning objectives, read some bios for our speakers, and then we'll go ahead and get started. So if you're having technical difficulties, there is a blue help button. Actually, I think in these Zoom rooms, we don't actually have that, but there is somebody in the room from Perform Media that can provide some technical assistance. And also you can put any problems you're having in the chat and we'll take care of you. We encourage your questions and interaction with the presenters. For questions during this breakout session, you can type a question in the chat or verbally ask the question. I think our speakers would like your questions in the chat for right now, and then we'll address them as we go. To ask a question verbally though, click on the icon labeled participants at the bottom center of your computer screen. At the bottom of the window on the right side of the screen, click the button labeled raise hand. The moderator will then call on you to ask your question, which you can do by unmuting your microphone. When you are finished speaking, please remember to mute your audio to avoid background noise. So upon conclusion of this session, participants should be able to identify emerging capabilities, documenting, and resources used to identify, aggregate, report, and analyze quality performance, create a one-stop shop for resources on education and marketing of current outcomes, identify new and quick tool for quality reporting of MBQIP measures and new measures of care to enhance overall CAW performance. So our speakers today are Margaret Brockman. Margaret has been the director of the Nebraska Office of Rural Health, overseeing the State Office of Rural Health, FlexShip, PCO, and loan repayment programs since joining the office in 2013. She is a master's prepared nurse with extensive background in both public and private sector work, as well as many years in academia. She has taught courses in psychiatric and mental health nursing, nursing administration, and case management nursing. She was the president and founder of a case management company for many years. As an entrepreneur, she enjoys developing new projects and methods in the healthcare field. She has worked in both rural and urban hospitals in positions as staff nurse, nurse leader, and nurse educator. Josie Rogers is the Director of Population Health for NEHII, which I'm sure that acronym will be introduced to us here momentarily. In her role, she works as a strategic advisor in adoption of health data analytics into healthcare practice as a population health data strategy. She also assists clinical staff with integrating NEHII data into the clinical practice workflow, monitoring and interpreting quality data, data validation, and assistance with data-driven improvement activities, MIPS, MBQIP, and other quality and public health reporting efforts. Prior to joining NEHII, Josie worked in quality improvement and healthcare operations roles at a Medicaid managed care organization, a federally qualified health center, and a community-based behavioral health organization. Josie received a Master of Public Administration in Healthcare Administration from the University of Nebraska at Omaha, and she also holds a bachelor's degree from Hastings College. And then we have Renee Town. She's the Director of Quality Programs at KPI Ninja and earned her Master of Occupational Therapy and Doctor of Education degrees from the College of St. Mary. Renee has experience driving performance excellence across a variety of healthcare domains through people and process improvement methodologies. Prior to joining the KPI team, she worked as a consultant, leading clinical transformation projects across the state of Nebraska. Based on prior experience as a clinician that drove outcomes patient by patient, she is motivated to leave a larger footprint by improving healthcare more comprehensively, population by population. Angie Charlotte is a registered nurse with over 27 years in the healthcare industry. She holds a bachelor's in nursing, master's in healthcare administration, and doctorate in business administration. Her passion and focus revolve around healthcare leadership and sustaining rural health. She holds certificates in CPHQ, Lean, and Six Sigma Black Belt, as well as the compliance team, PCMH facilitator specialist, and a certified John Maxwell leadership coach. Angie is employed currently by the Illinois Critical Access Hospital Network. So I will turn it over to our speakers.
Thank you, Nikki, for the introductions. So this is Josie Rogers speaking, and I'll go ahead and kick off our presentation, providing value to critical access hospitals, an overview of our MBQIP automation quality improvement project. And I'll turn it over to Margaret Brockman.
Great, thank you all. I'm so excited to be joining you guys this morning and telling you about our project. As you heard in the introduction, I am a person that loves to create new things, and I'm always trying out new things and seeing what we can do. And so I have two other individuals that have joined me in this project. Josie Rogers, she is the Director of Population Health with NEHI, and Nebraska has one HIE. We are fortunate in that sense. We only have one, and so she's with Nebraska Health Information Initiative. And Renee Town is the Director of Quality with programs at KPI Ninja. Next slide. There you go. So you heard the presentation objectives. We're going to define what MBQIP, you all know what that is, our partnership drivers for the program participation, explain the process of discovery, documentation, and the project build, and discuss emerging capabilities that leverage disparate data sources into a single view to produce insights into quality programs and initiatives while reducing the burden of participation. So the MBQIP overview, you guys are well familiar with MBQIP. Quality improvement activity under the Medicare Rural Hospital Flexibility Grant Program, or the Flex Grant. That's provided through HRSA. The goal is to improve quality of care provided in critical access hospitals, the cause by increasing quality, data reporting by cause, and then driving quality improvement activities based on the data. And that's been around for a while. So here's what we decided to do. About 4 or 5 years ago, we started working with our hospitals to have them work with NEHI and get involved with NEHI. And what we did with that was we went ahead and we looked at using some of the Medicaid 90/10 money to get them the funding to be able to provide the implementation and the interface money that they could go ahead and get involved. And so 2 years ago, I guess it was this summer, I was talking to NEHI and I said, I'm looking at our MBQIP program, and how do I make it easy for our CAW hospitals to go ahead and be involved in MBQIP and get that data? And can you pull that data? We had databases for quite a while that we had been putting all this information together. So we've been able to view the stuff in a database, but how do we pull that information for them so that they can use that information and make it as easy as possible that we could do this and make it free? So there are some of the hospitals that have the ability to do that with their EHRs, but they had to pay a vendor to be able to do that, or their vendor had to be able to do it for them. So how could we, as a Flex program, be able to do that? So we piloted 3 of our critical access hospitals starting in 2019, and then we extended that in 2020 and 21 to the rest of our hospitals. We have 64 critical access hospitals in Nebraska. And so over the next 2 years, all 64 have the ability to be able to do that because we were lucky enough to be able to secure funding to make that available to them, which we were so excited. We got a $500,000 funding grant to be able to do that through Medicaid for them, to do that at no cost for them. So really excited about that. So we started with 3. The participating agencies included the Nebraska State Office of Rural Health, NEHI, and then KP Ninja. The goal then was to improve the MBQIP reporting and the efficiency through the data and the reporting automation to reduce the burden for our critical access hospitals. So what was the involvement of the Office of Rural Health? Again, the source previously, the recruitment for the cause for MBQIP participation was challenging. We have to remember that, you know, MBQIP was voluntary. So as the quality people were getting requests for other quality programs, other pay-for-performance programs from insurance carriers, from other things, you know, all of a sudden we had competing, they had competing interests for their business and for their time and so forth. And so how could we make this voluntary program that we were asking them to be involved in more attractive to go ahead and be participating in? So, and traditionally, it has taken an extensive amount of time and resources to report MBQIP for us at the Office of Rural Health. So I'm going to turn it over now to Josie. So again, that's what started our partnership with NEHI and why we decided to go ahead and do this. And we were so excited. Like I said, I had no idea how we were going to do this. And so that's why NEHI and KPI Ninja are here to talk about how they did it, because I had no idea how it was going to be done. I just said, hey, can you do this for us? And these are the experts in how they were able to do that. So I'm going to mute myself and let them continue.
Thank you, Margaret. And you're being very modest about that part of your role. So you've had a big part in forming this. So I'll speak to first our organization of Nebraska Health Information Initiative, NEHI. As Margaret mentioned, we're the statewide health information exchange within the state of Nebraska. Each state is set up a little bit differently with that. Some have multiple. And so we're the one within the state, and our vision is to enable a healthier Nebraska and region through the availability of health information needed to facilitate quality, safety, and value in population health. We're a nonprofit neutral convener in the healthcare ecosystem, and we serve as a population health utility, wherein that we're really focused on advancing interoperability of healthcare data by taking disparate systems and combining them into one comprehensive longitudinal health record for the greater care outcomes of an individual patient, and then leveraging that data into a more comprehensive health history and record for health systems to do quality improvement efforts and population health activities. And so this project, when proposed by Margaret, was a natural fit because we're really always looking for ways to reduce the burden of participation in quality programs for the providers that participate with NEHI. And NEHI's role in this was really to work with Office of Rural Health to both identify the appropriate vendor for this project, to bring together the disparate critical access hospitals and to leverage their health data within this realm, and work with Medicare to continue to secure the ongoing high-tech 90/10 funding, as Margaret mentioned. And I'll let Renee Town from KPI Ninja introduce herself and organization too.
Hi, thanks so much, Josie. It's really a pleasure to be on the call today. So KPI Ninja, we're a healthcare technology company primarily focused on analytics. We're here supporting NEHI and through that supporting the Office of Rural Health. We're extremely passionate about improving health outcomes. So rather than just providing interoperability solutions or dashboards, we really see ourselves as providing the information that is needed to be the catalyst to healthcare improvement. We're slightly different in our market. We have an analytics as a service business model, meaning we don't just provide our tech platform, but we also provide what we call Ninja advisors. So these individuals who have expertise in interoperability, analytics, performance excellence, and so forth. So we support multiple HIEs across the nation. Very, very honored to be supporting NEHI. We support them on a number of population health initiatives. As a company, we are one of the most comprehensive analytics platforms. We hold over 4 NCQA different seals and certifications, HEDIS, ECQMs, PCMH, and PCSP. But at the end of the day, when I think about the audience here, KPI Ninja, our first client, was a rural health clinic in a critical access hospital. So we very early and intimately understood the data problems. So this project is very close to our hearts, and excited to be here with you.
Thank you, Renee. So as Margaret mentioned, we went about the pilot project starting in 2019 with 3 critical access hospitals, their names listed here and their bed sizes. So we went through a whole pilot phase with them, which we'll kind of describe in greater detail throughout the rest of the presentation. And then we have continued to recruit additional facilities. We have facilities in flight, and we are meeting with interested facilities throughout the state to maximize our remaining high-tech 90/10 funding through the close of the 2021 fiscal year. We went about recruiting these facilities both through connections that Margaret, of course, is very well connected throughout the state with critical access hospitals. So she and her Flex team have been great advocates for the program. We've also done local conference speaking engagements collectively, surveys, repeated demonstrations kind of as requested and helpful for the critical access hospitals, and then calls to kind of gauge fit and need as a follow-up to all of those. So quite a bit of kind of pre-planning and comprehensive work to determine where we can best fit and help with the need within the state. So that's been exciting and a great way to build the connections with the critical access hospitals. So in addition to those listed on the slide, we have 4 in flight now and several others in recruitment as well. So when we went about starting this project, we knew that there were several barriers that critical access hospitals are facing with consideration to participation in MBQIP, particularly depending on the sophistication of their electronic health record. We know that many critical access hospital staff go about the MBQIP process manually with manual chart abstraction that can take sometimes hundreds of hours annually to complete. So we knew that that was a burden and a barrier to participation for some. We also know that some of our contacts with the MBQIP program are wearing many, many hats within their given critical access hospital. So that primary reporter of MBQIP may be also overseeing the lab, maybe a nurse on the floor, maybe clinical informatics specialists as well, just wearing lots of hats and having a lot of tasks on their plate. In addition, one of the other barriers we were seeing because of some of these aforementioned barriers was that we're seeing in many of the critical access hospitals that because of the burden of pulling out those data points, some of our critical access hospitals are really experiencing lagging performance data and the inability to see their performance in a quickly enough time frame to be able to action kind of barriers that come up. So really looking at a lot of retrospective review rather than kind of near real time. So those are some of the things that we, again, with our many partners, in critical access hospitals were identified as barriers to kind of the then current state prior to launching the project. So we said about this by starting with the discovery phase with those 3 pilot sites. We use that discovery phase to really gather a lot of information about current practices and kind of current needs. So we met with those 3 sites, identified the MBQIP measures being reported, understood their electronic health record being used, the pattern of work amongst the care teams, and the documentation practices. So looking for discrete fields that we could pull data points out to start documenting. And then really, of course, one of the important parts was just understanding team members' roles and their level of proficiencies with the MBQIP reporting task, and also their comfort with their EHR. We would go about examining the inputs needed and steps performed, timing of resources in the reporting process. And then once establishing that those items, we would go about actually integrating with their electronic health record through virtual private network VPN to access the data points needed to kind of continue with a more efficient and automated pull of those measures. So then we would move into the design phase where we collected the quality specifications, build the measures in reports and scorecard through the VPN connection. So again, a kind of a collaborative and iterative process where we would look at the MBQIP specifications, understand how they were the critical access hospital was documenting those, and then working collectively to pull those out and validate them. In the design phase, we also went about the creation of quarterly reports to those specifications, including the fields mentioned, and importantly, the quarterly trends for ease of interpretation to drive improvements. Within this design phase, we really looked to kind of be collaboratively building in the most effective way possible for the critical access hospitals participating, and then pulling reports in a manner that would be most efficient for upload to the CART and other tools. And with that, I will transition to Renee Town for kind of discussion on continued phases of the pilot project.
Yeah, awesome, Josie. Great overview of the discovery and the design phase. Just one quick element I wanted to add in that. So as Josie detailed, the discovery phase was all about learning the MBQIP processes at each facility. So what measures were they reporting? What were their documentation practices? Where did that data live? And then what were the quality staff or the HIM staff doing on the back end to pull that data? Set out on the pilot, we know there's many different ways to share data throughout the ecosystem. You know, working with NEHI, we've leveraged many of those, you know, many industry standards, HL7 and CCDs and many other things. But I think it's worth noting that the data elements within the MBQIP program measures are very unique. And so we took an exploratory approach in the pilot, but ultimately realized that direct database connection was critical for getting the most data elements that we could. This is something where, with our work with NEHI and other HIEs across the country, that's pretty innovative. Not many are doing it, but realizing the benefits of it beyond just, because even the most comprehensive CCD has very few of the data elements, as I'm sure everyone on the call here knows. So quick segue from the discovery and the design phase, ultimately to get to implementation. So once we had a true understanding of current state and where we wanted to be, we looked at those deltas and said, how can we leverage technology to reduce the burden and enable improvement? That was the overarching theme or objective of this project. And so when we did that, we looked at technology from a number of different perspectives, and we did that through the implementation phase. Anyone who's tried to drive healthcare improvement knows that implementation is a science in its own. You can have the perfect solution or countermeasure, but if it's not rolled out well, you risk losing any positive outcomes of that. So we stay very, very close to the scientific method, the implementation phase, with phased approach to addressing unforeseen obstacles as we could embrace segments to help improve that learning. So with the facilities, steps we took from the student here. So the first one is to extract really data. Our version of that, because we do it, look for MBQIP measures, focus on leads, point a few data elements. And from there, we start the data validation process to identify is accurate representation of performance. And so if there were, we would continue on in the phased approach. If there were any data gaps, which are always a different projects, the learning process for the technical team, as well as the I like when we experience data gaps, is we have what we call documentation practices called what we learn from those frontline staff documenting. field. So data realized we don't represent 70% of performance. So we need some other people to be able to be part as well. This is an example of how we improve the documentation apps on the back end. There's also a discussion with the facilities of improving documentation on the front end. You know, where the point of what those clinicians document, because they realize that if you document in a consistent manner, not only will it help with reporting, but more importantly helps with communication and service delivery. So I wanted to provide a few examples of how we have those documentation apps. Ultimately, it goes through levels of data validation. The first is the technical, that's our KPI. We get that database access. So we assure that our queries are actually pulling where we say to, pulling from both fields, relationships between them, are communicating appropriately. So the first level of data validation. I provided a set level with overarching as related measures, and then facility could have access to their own local context and how things are documented. Once we reach the point where we feel is a representation of performance, we adjust the data, then it goes to the data pipeline, automate the process, and show you what we help with here next. So high level implementation, we co-design the analytics based on the needs. You see today was direct feedback of the facilities that they wanted as related to the physicians, reports, and so forth. First example, even our making changes, we also even with our the other the presentation was very different, but nonetheless, this is our scorecard. So it is supposed to be a high level succinct summary facilities performance across all four categories of performance. So you can see those four categories, the measures in them, and performance. What we heard from the facilities is they really wanted an easy way to bring that to their board coordinating committees and different teams. So you can go right hand side under status, color code, drive by, they're doing well and they're doing good. So that's one example of some features in the middle of the platform. The second one is the JC held earlier. One of the things we heard, the inability to see data in real time, especially when we're implementing a process change and understanding the changes we make actually have the outcome that we're seeking for. So obviously this sort of integration we have real-time data. And so with that, it's easier to visualize the data and see it in real time. So an example, I think it's historical quarterly, breaking it down to the weekly level now. Of course, the data expert would break it down to JPEGs. Again, this is internal external reporting requirements. You don't have a chart here, but the other element that we have provided as part of reducing the burden is the user level reports. So we're going to talk about that shortly. For each measure, an application, they can go there and click and create a report. So all those key data elements that they need to report. So we haven't automated that quite yet. Nonetheless, the export report exactly follows the format of part. So really use the training tools. We heard from that part is patient data requires a little bit of HRs, spreadsheets, and so forth. So we wanted to reduce the burden as much as possible. So it is kind of a direct mimic of the two. Lastly, let me take off the slide for this. This is a big opportunity for Josie and Margaret to share their perspectives of the outcomes as well. So as you can see on the slide, to figure out success is the ability to disseminate on the reporting process. That's what we've done that. Success from tracking that data out of the database of the EHR. It does very based on a number of factors. Nonetheless, we have had facilities 100% success using hours, as I mentioned earlier. They are proficient in dashboard now. They can see the performance in full time as we're receiving those reports from them and also verbally for submission. That goes to Margaret. I'll hand it over to you guys.
Thank you, Renee. I'm going to move to the slide, and there's a number of questions. I think you quickly answer. I'll be respectful of time. I'll do a quick check with Nikki. If you would do a high level answer all these questions quickly, or hold, would you like me to word in the chat when you present? Okay. Yep, we'll do that. I'll keep watching the chat and while Angie presents if folks have additional questions. Thank you.
Sure, I can. It's really kind of been very similar to what I've done. We can have a lot of trees regularly and recording. Similar to everybody, I think we're all experiencing these same challenges. You know, typically there can do reports if you want to. I can imagine having 64, and getting all those individual reports. Reports for from the board report. One of our colleagues is really just having the ability to manipulate and trend resources for equipment or in their location. They want to go one stop shop. And the other thing that I asked for was marketing. How do we really demonstrate what we're doing and what we're doing quality initiatives. And the question is so that we can submit that. So what was with the team survey cause. And I know our core area of focus, evaluate several models on what we could do. We looked at Tableau, our dashboard, from the university, and really started looking at some of the practices to build this out. And we came up with those MBOIP.com. And this is a labor of we'll be taking on that project here at the end of the month. But they have to evolve. A lot of updates still enter, and if you go on here and it's open, you can make the most part. You can see there's still some that to be changed or updated. It's easy to access. It provides a link automatically for data collection for lawyers to submit to the state audit. There's a marketing and art department really enhancing the way so we can shine on what we do. You know, the big thing that we look at in our hospitals, what you ask is how can I generate quality outcomes with our data? Market is not tertiary, and we are primary and secondary markets. And we're going to find ways of really practice sharing and links to resource sites. So that's a very key and simple. Your name and email address the first time and kind of just search that computer. You must see the end in order to access the data. So as we go through, we have our way of example we're taking. And what it does is they click on a bubble, and the most recent data out there is what you come up. And you can see there's multiple tabs when you click on that. So then you go to the course, you must see the number to access your actual hospital. And come up with the initial from television, you know, what the reports look like. But then it takes it further and you can start looking at this might be able to actually trend it over time and make it board friendly and you can download it so you can make a PDF friendly, PowerPoint friendly, you know, to present to your board. And very similar to task. And look, but if we measure, and this one was really exciting for people because they really like the ability to so similar, you click on the bubble and you can look at your report and it automatically comes up with that PDF that we see that breaks it down a little bit further. Those tabs is about the same on every page, one or pages. So news resources, marketing, education, reports. And we have the open the star ratings on here, you can see where they work over time. But then it breaks it down a little bit more friendly for trending purposes and for reporting. But now, we have the majority of our hospitals use better vendors already give them more up-to-date information. So, you know, all going to be a hindsight and recognize that. But they really like the art department. They can go on and submit all their information. They can get assistance through the platform or they can do it themselves. And it's free marketing, and there's some that they do, and looking at what they want to enhance or they can look at those we have now, and they can just, you know, and it just really creates something that robust, you know, to demonstrate. Is to demonstrate, you know, the metrics and market to our, you know, primary and secondary market. Again, looking for ways to submit data. Here we don't have a source HIV. It's just there. So we looked at the survey. This is always up and running, and it's always the next quarter ready to go. And you only have another tab at the end of their submissions. And hospitals can go in and submit their data for us. And then we can submit to all the folks. Our development is certainly additional options when they quit. But our quality we're finding is required all departments to do quality improvement. And we have been doing this behind the scenes in departments, and we can launch our opportunity. Those, by the way, are open national. So any state can provide, you know, can participate with us for a very nominal cost for the platform. But again, this one has truly been exciting. that there was nothing to really enhance the ability to see how they were performing against others. I've been doing manually for more than 3 years, actually, it's probably 5. And this finally fruition, and it is to allow the ancillary departments to also have those quality metrics. One of the things that we continue to hear is that how do we have any idea of those measures? And so while still in progress, it really is becoming an amazing platform. Right now we have our dashboard, and there's a few other pieces that are in development. Yeah, and I don't think that I can participate right now, but they have been open to it. So the program overview section, it kind of gives you an idea of what we're looking at and what we're doing. And it's really as a mission. The straight up, like Excel file, so the question structures that they're looking at, they're already out for, your accounting or your other areas. And you can see, just a brief look of what that may look like. Cultures, what we're looking at on each division, and this is through their benchmarking advisory teams, and they wanted to have. For that, this is great because they actually have information on evaluation. This is perfect. You really enhance that performance as well. This one's a little busy, but this is work hours, and it has been how is this information coming to us? So you'll see the hours explained, the benchmark, and the calculation in each one of the measures that get built. And then what's next? Really looking at that really going for best practices, what can we do easier, for marketing and reporting. May change as we continue to work on that, and innovation of new measures, especially with our collaboration with the new project, which is satisfaction. We're doing now. We have a pilot with that we are doing, and the measures that are going to be coming from that is going to be in here with here in Illinois. And they're planning it. Traditionally, all of them are part of the education participation, and we adding all of those in as well. And we can really start to enhance this. And our QIP is working with their team on getting our hospital engaged. Our CFOs absolutely love this because there's productivity measures and really looking at numbers in the current that component of it. And like I said, I will leave it so we're taking this on these are as well. So that's all of my presentation. I pray because I know I have limited time, so and then I get to the chats. All right.
Presentations were great. I actually have not heard from my technical systems rollout. They're one of these things I'm seeing people could argue about. Thanks for sharing it. It's very cool. So comments, I don't see any questions. Roughly 2 minutes. Somebody else had a question in Nebraska or a question for me. Unmute your mic and ask it. Any question I answered, maybe everything you needed. Okay, I'm going to ask everybody other questions answered. So, I'm going to attend the meeting until 12 Central Time. At the conclusion of the breakout session, we click the links to the upcoming breakout sessions will be available. But anytime you need to lose connection, note you can always refer to the portal to access live